Good afternoon, everybody, and thank you for the lovely introduction. My presentation today would be all about women. We are discussing treatment considerations in both cisgender women and transgender women, the barriers to overcome and strength to reinforce. So without further ado, let's take a look at the HIV and AIDS situation in both populations. For transgender women, HIV prevalence and the number of new cases decreased over time. In 2022, transgender women accounted for 3% of newly diagnosed cases of people living with HIV. Be that as it may, transgender women are still a part of a key population which contributes to the majority of new cases in Asia-Pacific region. As the median prevalence in transgender population decreases from last year, it is still the third highest among all population in Asia-Pacific region. Why is that the case? According to HIV and Young Transgender People Technical Brief by WHO, there are many barriers which hinder transgender women to access sexual health-related services. The first is the vulnerability to HIV infection, for example, higher rates of unprotected sex and misconception of the risk, social marginalization and identity crisis during adolescence. The second is legal environment and how many countries in this region still criminalize transgender people or do not recognize them legally. The third is about accessibility to healthcare services caused by the service delivery itself and the stigmatizations. As for cisgender women, the number seems to be a bit better in our region compared to that from sub-Saharan African countries, where more than 60% of new cases were cisgender women. In 2021, women contributed to around 32% of the new people living with HIV cases in Asia-Pacific region. However, it's important to clarify that this doesn't imply cisgender women do not need particular healthcare services. There are barriers specific to this population, for example, a higher gender-based violence, domestic violence, and contraception coercion, which are directly related to the violation of basic human rights, and indirectly relate to the poorer uptake of ART. Not to mention the women in the key population, such as female sex workers, which experience even further discrimination and may result in even more poorer outcome of ART. Now, moving on to the treatment considerations for these populations. I would like to divide this part of the presentation into two sections. The first one, we will be talking about the considerations about the ART itself, and the second part would explore the considerations for specific service deliveries for each populations. Firstly, there are various ART regimens available in the market today. Each one has different side effects and drug interactions. These are the examples of a famous and most available ART regimens in the market. There are a few things that needs to be considered when prescribing ART, one of those being its effect on family planning. Some component of ART, such as DTG, was believed to cause a higher risk of neural tube defect in infants. However, the recent data from guidelines for the use of antiviral agents in adults and adolescents with HIV indicates that the prevalence of neural tube defects in infants born from the women who take DTG at the time of conception is not significantly different from those who do not take DTG. At the bottom left corner, you will see that the list of the preferred ART agents for women in reproductive age with a childbearing potential. And you can see that DTG is also listed as a preferred INSTI agent for these populations. Nevertheless, folic acid supplement prior to the conception and regular ANC screening with ultrasound anomaly screening at GA18 to GA20 weeks should be advised to reduce the chance of neural tube defects in infants. To the right is the list of different types of contraceptives and ART components that affect their effectiveness. Each contraceptive methods has different types of estrogen and progesterone hormone. Some has both combined. The ART component that has drug-drug interaction to almost all of the methods is efavirenz. Efavirenz can decrease the effectiveness of combined oral contraceptives, intravaginal ring, progestin-only pills, and progestin-releasing implants. And the only method that is suitable for efavirenz is the MPA injections. However, there are a lot more ART regimens that you can choose for your clients that do not involve the decreased efficacies of these contraceptives. Another effect that should be considered in cisgender women is osteopenia and the osteoporosis as well. Since people who are assigned female at birth are prone to this condition, it is very important to inform women living with HIV who take specific component of ART to understand the risk and the benefit of the ART regimen they are taking. The ART regimen that contains TDF or tenofovir diproxyl fumarate and ritonavir boosted protease inhibitors can cause greater BMD loss or bone mineral density loss compared to ART that contains NRTIs and lopinavir. Abacavir, TAF, and other NRTI-sparing regimens are preferable in a high-risk group. However, this does not mean that this agent should not be used with cisgender women living with HIV. To further reduce the risk of osteopenia and osteoporosis, BMD screening should be monitored regularly, especially while they are using the aforementioned agents. The discussion would evolve around weight gain as well. For some people, weight gain is a desirable effect of ARV initiation. However, for some, it is a barrier to initiating ARV, especially in transgender women and cisgender women. The knowledge surrounding the ARV and weight gain is still unclear, but we still see some patterns about sex differences in the matter. What we can conclude is that there are sex differences in ARV-associated weight gain, particularly in INSTI-based regimen. We see that women are more likely to gain weight comparing to male counterparts. Another thing that we need to discuss is the pattern of weight gain. It is also has a sex differences. We see women gain more fat than lean body mass, meaning that most of the weight that had been gained by women are from fat. Specific agent also has effect on weight gain. For example, bictegravir and dolutegravir, which has been associated with greater weight gain, and also TAF or TAF is also associated with greater weight gain comparing to TDF. Moving forward for the transgender women, the quintessential aspect that should be considered in this population is gender-affirming hormone therapy and its effect on ARV. Most of the transgender women use gender-affirming hormone therapy. The recommended regimens were 17-beta-estradiol and cyproterone acetate. As for 7-beta-estradiol, it can mildly decrease FTC and TFV area under curve, but less than 30%. Therefore, no dose adjustment is needed for ART initiation. However, evidence shows that some ART component may affect estradiols and testosterone's efficacy, namely efavirenz and nevilapine. The agents that do not affect gender-affirming hormone therapy efficacy are all NRTIs, bictegravir, dolutegravir, lopinavir, RPV, and DOR. So that is more preferable in this group. And that is it for the ARV considerations. Now let's move on to the service delivery considerations. When we talk about healthcare priorities among transgender women, multiple studies shows that gender-affirming hormone therapy service is an utmost important. Therefore, the integration of gender-affirming hormone therapy to ART services should always be considered. Luckily, both services complement each other perfectly in terms of scheduling. Both of them requires only 1 to 2 visits per year. As for the current ART services, the blood collection should be collected for HIV RNA assays and CD4s, which were needed only every 6 to 12 months. and that accounted for 1 to 2 visits per year. And if you take a look at gender-affirming hormone therapy regimen, you will see that in the first few years, there is a need for blood collections in every 3 months to monitor their hormonal level. However, after 6 months to 12 months, the evaluation can occur more scarcely. The hospital clinic visits falls around 4 visits per year on the first few years, and after that, only 1 to 2 visits per year. Another aspect that has been neglected in sex is the sex reassignment surgeries. Evidence shows that gender-affirming hormone therapy and sex reassignment surgery can substantially boost the psychological well-being of transgender people. This helps improve their self-esteem and eventually lowers HIV risk. However, due to limited resources, especially in low middle income countries, the likelihood of establishing SRS or sex reassignment surgery center along with HIV services is quite low. Nevertheless, only information about gender-affirming hormone therapy and SRS is a valuable asset enough for them to come in and receive the services. So providing this information to the clients can help attract the clients in this population to enter sexual health services. Moreover, it needs to be informed that HIV infection is not a contradiction for sex reassignment surgery. After transgender women or transgender men who have been suppressed virally can also enter the care of sex reassignment surgeries. Moreover, transforming the location for ART services to a more gender-sensitive location may help improve the willingness for transgender women to come and receive ART services. There are a few things which can be done, for example, pronoun badges. This can alleviate providers' confusion when calling gender-diverse clients and increase comfortability for the clients as well. Second is prioritizing chosen names. This can also help alleviate discomfort for transgender people. Thirdly, deploy peer support or peer navigations. This can also help increase the jobs in HIV-related services for the transgender community and also be a comfort zone for them to come in and receive the services. Fourth one is the gender sensitivity training for providers. It is important for every provider, whether they are the member of LGBTQI+ community or not, to be more gender sensitive when giving or providing care for transgender populations. And the last and the most important thing is that the health and well-being for the transgender people. We can also support that by providing gender-neutral bathrooms for them, especially in ART services location. Moving on to women living with HIV. Women living with HIV also face the violation of reproductive rights in healthcare settings. For example, conditional antiviral treatments, coerced sterilization, and coercion of contraceptives and family planning. A recent study from Lyons et al. Found that women living with HIV in Central Asia experience coerced sterilizations and coercion of contraception during medical visits. The data regarding gender-based violence in Asian countries is still limited, so it is important to address gender-based violence in your own setting. Better yet, collect data about it for future advocacy. With that being said, I would like to address a paradigm shift on the subject related to HIV. For the longest time, the medical professionals focused solely on people living with HIV survival because 20 to 30 years ago, the innovation of HIV treatment and prevention is not as progressive as today. However, we are moving forward with a new perspective. It is time to change our priority to also focus on quality of life. And what I mean by quality of life is, for example, the rights for women living with HIV to reproduce and fulfill their motherhood. This is why it is at most important to eliminate reproductive coercion in medical settings. Another controversial yet essential aspect of quality of life in people living with HIV is sexual pleasure. It is widely known that a large number of people living with HIV were told by their doctors not to engage in condomless sexual intercourses or even any kind of sexual pleasures, again, for fear of spreading the infections. That is an absolute point of view, and there are tons of reasons why I think that is. Nevertheless, the most important one is the knowledge on U equals U. U equals U stands for undetectable equals untransmittable. It is a concept based on 3 clinical trials that recluded serodiscordant couples, whether they be heterosexual couple or men who have sex with men, whose partners were diagnosed with HIV with viral load less than 200 copies per milliliters. In these 3 trials, combined up to 120,000 condomless sex acts, and they found zero-linked transmission of HIV among this couple. However, in the last month, WHO has issued a policy brief on the role of HIV viral suppression in improving individual health and reducing transmission. In this document, the definition for viral load suppression and detectability has been altered. The first definition is undetectable viral load. It means that the viral load is not detected by the test is used. If a person have achieved undetectable viral load, it means that they have zero risk of HIV transmission. Another definition is suppressed but detectable, which means that the viral load less than 1,000 copies per milliliters. People who achieve this state almost have zero risk or negligible risk of HIV transmissions. U equals U is the target of antiviral treatment. It is the whole purpose of ART, and to communicate about this fact can help increase adherences to ART. They can also help empower those living with HIV and restore their healthy sex life that may have been impacted due to the infections. However, the barrier that hinders this concept to achieve its goal is the willingness of healthcare providers and KP-led providers to communicate to clients about it. Though some of them perceive the concept as too bold or progressive, it is scientifically proven, which makes this concept a scientific fact, which is why we as providers should learn to confidently communicate with this, about this with the clients. And I would like to leave this stage by introducing you to the sexual health section of the SIRO publishing. This will also combine the global evidence of implementation science of U equals U around the world. So those of you who wanted to learn more about U equals U and how to implement U equals U in your setting can also do so and refer to this publishing. Thank you very much.